Hi, I'm Vicki Miller, the Patient Education Manager for the CLL Society, and we are here today to discuss a paper presented at ASH 2023. We are joined by Dr. Brian Koffman, who I invite to introduce himself.
Hi, Dr. Brian Koffman. I'm a retired family doctor, a CLL patient myself, and the co-founder, chief medical officer, and the executive vice president of the CLL Society. And thank you, Vicki, for interviewing me about this ASH paper.
You're welcome. Thanks for joining us today. Can you tell us about this paper and what the study was about and why you did this research?
Yeah, so the paper was titled Patient Preferences for Fixed versus Time to Progression Therapies in Chronic Lymphocytic Leukemia. And as I think everybody knows at this point, the novel therapies, these oral targeted therapies, have revolutionized how we treat CLL. And patients have a couple excellent choices. One broad class of drugs are the BTK inhibitors, and they are generally taken until they're no longer tolerated or the disease is no longer responding. So they take to progression. But another class of drugs, venetoclax, which originally was being studied with that same kind of model, but almost is exclusively used as a fixed duration therapy, often in combination with an antibody, an anti-CD20 antibody like rituximab or obinutuzumab. And these are two excellent therapies with very high response rates in all comers in CLL. So we wanted to get a sense of which did patients prefer, what was important to them. And I can go ahead and explain a little bit about how we did this research, if that'd be interesting to you.
That would be, please.
Yeah, so we had really two ways of looking at it. We had a small group of patients, which was this sort of a qualitative phase where we had in-depth interviews to find out what was important to patients, what was going on in terms of what they considered. And then we did a quantitative phase where we asked patients, and this is a complicated concept that we used here, but these were questions that we'd ask patients, and this was based on what's called a web-based discrete choice experiment, or DCE for short. And what that meant is that we'd compare two things. How and what are you willing to put up with to get that? So are you willing to put up with a 3% risk of atrial fibrillation with this therapy, or a 5% or a 20% or whatnot? And we were trying to get patients to compare one thing to another and rate what their preference was, their maximum accepted risk, or MAR, of a treatment adverse event, to see what was going on. So the original interviews were done with 20 CLL patients. The average age was 59. We find that in trials, the average age is always younger. And a larger percent were females, 55, even though we know in CLL, it's probably the ratio is reversed or even higher, but females tend to enter trials more. The average time with diagnosis was 3 years, and 70% of the patients had received therapy for their CLL. So they looked at different attributes, and the main things that they kind of looked at was treatment duration as being very important for their treatment. The second part, which is the DCE, this discrete choice experiment, where you say, if not this, that, what would you prefer? There was 229 patients with a self-reported diagnosis of CLL for the last 3 months. Again, similar age, a little bit older, 66 years old, and 60% in this group were females. About 60% was diagnosed 5 years or more, and 2 out of 3 patients had had treatment for CLL. What was found here is that patients were willing to accept a 6-month or 12-month fixed duration therapy compared to treat to progression. And they were willing to accept more than a 3% risk of tumor lysis syndrome with that, more than a 7% risk of atrial fibrillation, and surprisingly more than a 21 or 26% risk of fatigue. So this says people were willing to put up with a fair bit. What we found is there was no difference in the 6 or 12 months progression-free survival. That didn't seem to make a difference. And it seems that given all things being equal, therapies being equally efficacious, and at the CLL Society, we always talk about what we really want to know is, are you going to live longer? What's the overall survival going to be? What's your progression-free survival going to be? That should be the number one determinant. But assuming those things are pretty equal, patients prefer that their therapy be a limited duration, a fixed duration, over treat to progression or treat to intolerance. And I'm just going to share with you just some studies, and this is from the why patients preferred this. And it made budgeting and anticipating expenses much easier. It was convenient not having to take treatment. Patients like freedom from therapy. They felt more in control. They didn't have to refill prescriptions. They didn't have to travel for a clinical trial or other problems. There was, there's no side effects from the medication when you're not on the medication. They felt like they could kind of forget about their cancer. The concern on the con side was, I'm not doing anything for it. Could the cancer come back again? For the smaller group, and the vast majority preferred preferred to be treated on a limited duration therapy, they liked the fact that they were doing something. There was a comfort gain by taking action and treating their cancer. But there was the worry on the other side, on the negatives, that it may become ineffective at time. There was the cost of therapy. There's the constant reminder that you have cancer. There's the inconvenience. There's the refills. There's all the follow-up that you need. And there's the risk of side effects. So we'll put a link in to the actual study, but you can see the actual data and the information behind it. But I don't think it's surprising that patients prefer to get off their therapy if it's equally efficacious.
It is really interesting that you did this study, though, and to get that data, even though, like you said, it's not very surprising, it's good to see it come out in the results. Do you have any final thoughts that you want the patients with CLL and SLL to understand from this data?
Yeah, I think the important piece of this is that your preferences should be part of your decisions, especially in CLL, when there's often this shade of gray versus this shade of gray treatment. There's not a black and white. This therapy is clearly better. If that therapy is clearly more efficacious or clearly safer, fewer side effects, that's the therapy to go with. It doesn't matter if it's fixed duration or if it's, take forever. But a lot of times in CLL, there's, it's 51-49 kinds of decisions that you're making. And if that's the circumstance, it's important for your doctor to know what your preference is, what's important to you, what you need to deal with. And so this tells us what a group of other patients felt about it. And the majority said, I'd put up with the risk of tumor lysis syndrome at the beginning. I'm willing to tolerate even a small risk of that. If it got higher, maybe there was less tolerance. But that's not you. So you have to make your own decision with your physician in a shared decision-making, saying, hey, I want the limited duration therapy, or hey, I want to treat till the disease progresses. I like the comfort of taking the pill every day. It's going to be different for each patient. And that's why we believe that communication with the doctors and educating yourself is so important.
Well, thank you. This has been very interesting.
Thank you for the opportunity.